It's great to be here in Switzerland, and I'd like to thank the organizing committee and my good friend Mario Bazzini for inviting me here. This is my several times I've been here to the country, and it's one of my favorite places to visit from the United States. So again, I want to thank the organizing committee for having me here. It's always a pleasure to come visit with my friends from around the world. When we talk about what do we need to know, and you're going to hear a theme, I think, from what we've been talking about here is, I think specific to some of the things I do, we try to reverse engineer a problem. And things I think we need to know are what are the risks, and what do we know about injury? What type of movement tests do we need, and how do we choose them? And then how do we interpret and utilize some of these results? If I go back and look at my career, and I try to figure out what is the problem, and the problem, I was in this boat because I used to see lots of knee injuries and some of the things the presenters talked about yesterday. And what I learned over the time, especially with the elite athlete, is that our traditional isolated approach to either our evaluation or treatment doesn't necessarily restore the whole of function. In other words, what I'm saying is we can get really good about some of the things we do. And early in my career, and we heard even a nice survey from Nikki yesterday talking about this with her data, that largely from a traditional viewpoint, return to play guidelines were based upon pain, range of motion, and strength. And some of the things I've learned throughout my career is while we're really good at this as physiotherapists who can get these things back, that doesn't mean that our athlete's going to go back to the highest level of function. In fact, what I try to get here is movement. And that's what I'm talking about here. We're looking for superior movement. Now, it's not the cheetah here. This is what we'd like to see our patients to be able to do when we get discharged for our return to play. That is ultimately the criterion I'm looking for to help out. Or if we look at some clients we work with in the States, this is superior movement right here. This is testing that we do for players to get into the American football. They come in for a combine and they're all checked out. But here we can see a large person being able to jump over 12 feet and on a vertical jump almost 46 inches, pure vertical jump. That's superior movement. That's efficient movement when we look at things to go on. Now we say, what do we know about injury? We heard this yesterday as well. What is the best predictor of injury? And we've looked at all kinds of markers. But what's amazing is the #1 predictor of injury is previous injury. Now, does the research support that? We've heard lots of research in the last couple days, and it's been ongoing when we look at the research that's out there. And there's been multiple prospective studies looking at this, showing that previous injury is a significant risk factor. And the data is kind of all over the board, and people ask me all the time, well, there must be something wrong with these studies because the injury rate, as we can see, are 2 to 19 times greater risk of injury. Why could it be that much? Well, it's that much is because our players go back to various activities or various sports. I'm sure if somebody was going to go back to being a professional chess player, I'm pretty sure that the injury rate would be almost nominal versus going back to playing a contact sport, the injury rate is higher. And when we look at some of the recent data, and these are all studies from the last couple of years, they're coming out much more frequent in our literature, but this was a study from this past year that looked at, again, with American football, if a player, when they come in and do that combine for testing, if they'd had previous history of low back pain, is what this study looked at is, or something that they'd reported, self-reported this, they were less likely to get drafted, and their careers, those that did get drafted and go on and play professional football in America, their careers were much shorter and they had much more time loss. So this is telling us, well, if there's been previous injury, obviously that leads us to something else. We've saw some variations of this in the last couple days. We're looking at soccer or European football. #1 predictor of injury, previous injury, looking at large numbers. A paper just came out last week in the United States. I was looking at this one at special forces operators that we have in our military. And the #1 predictor of performance and looking at things was previous injury. And I'm talking about people that had gone through rehabilitation and discharge had gone back to active service at the highest level, but yet they still had deficits that affected their performance when we looked at this, even though they passed our other biomarkers for moving forward. And the biggest one, I think, is sort of graphic to me. We've all sort of this morning, each of us have said something that was kind of an interesting study, and this is the last one I'll share, but this was a study looking at prediction of injury from high school athletes to college athletes in America. And what they did is they clumped athletes into categories of previous knee injury as one group, and or had they had an ACL tear, and they put them in a group. And then they followed them through their collegiate career of sports, and they found that there was almost a 900% likelihood those that had had ACL injury in high school were going to have surgery again in their 4 years of college when they played sports with this. On average, they were going to have at least one MRI a year for looking at healthcare costs and doing things, and their careers were much shorter. Time loss was greater. And this is some dangerous information for administrators in sport, because they start looking at this and start saying, well, we probably don't need to bring these kids in, or we don't need to give them scholarships for education and play, because these are going to be a significant drain on the healthcare system. I look at this problem and say, who owns the problem? And I try to figure this out, and I think the problem really is ours. We own this problem, because either we're not fully rehabilitating our patients when they come to us, or something else fundamentally or structurally changes after injury. And you see I drew arrows up here because I think they're interrelated. I think one leads to the other, that something changes, and quite possibly we're not addressing the problem. And the area where I think we're lacking quite often in our rehabilitation is from that, bridging from that traditional point to where we need to be now, and that's looking at motor control. That we know following injury, motor control has changed. I sort of draw it as a triangle here. Injury and pain, we certainly know are interrelated, but both of these can affect motor control and have motor changes. So we move differently. We move differently after injury. We move differently in pain. And these are the things that need to be addressed. Now, people say, well, where do we begin? Well, you can see up here in our sort of this diamond-shaped diagram of where I go with movement testing with all the clients that I work with. And there's a line right in the middle here. And this line in the middle, to me, is the pain line. If pain is present, that's a different animal. That's a different game we need to play and work on. Because we just said on our previous slide, I know pain's going to change motor control. I know pain's going to change the way we move. And sort of clinically, that's what we're dealing with when individuals come in. And we have a whole separate movement screen that we use for people in the clinic that are in pain to assess what are the impairments, specific impairments. And I break this down to 3 Ps: parts, patterns, and performance. If somebody was healthy, or I'm ready to discharge a person from my care and start them into return to play, and that's where I would use something like a functional movement screen. Now, the functional movement screen, many are familiar with it here in the room. It's a 7-little screen test, and it is nothing more than a screen. We look at squatting maneuver, stepping, lunging unilaterally, so we go to both sides, sort of a reaching for the upper quarter, leg raising, push-ups, and then a rotary stability test looking at the trunk. Now, weigh this is a very simple screen. We look at this, it's scored from 0 to 3, 3 being optimal, 1's dysfunctional, 0 person has pain. We run through these, and there's a maximum score of 21. Now, I think it's important to note with some of this, the data is all over the board on what is optimal. This tool was never designed that 21 was perfect and that's what we should all strive for. In fact, every sport's a little bit different. Every athlete is different depending on their body sizes. So I call them medal brackets, that we have individuals that maybe this group needs optimal for this group is a 12. Optimal for this group might be 14. We have different scores for some of these things we look at. Does the research support this? The good news about testing with our functional movement screen, it is reliable across raters. So that's a psychometric property of any of the tests we need to be able to do that's reliable or reproducible. There has been some information out there that a composite score of less than 14 is predictive of injury. However, to be fair, and I gave several of the studies that are out here looking at this to support the under 14 cut score, composite score, I can tell you we could probably go out in this room and find just as many studies that say it doesn't predict injury. So I put up here, it's still questionable and group specific. There is an ongoing study right now that is showing that probably the 1 factors, or from those composite scores that mean the most to us, are asymmetry scores. When we look at right and left, those do appear to be the case, at least with National Football League or American football players, that is highly predictive of injury. And the other good thing is not only do we have a reliable tool, but can we use it as a marker for performance? Can we train to this? And we're now finding out it is a modifiable score with training programs. Now, it's a screen. I think people put too much credibility in this system or in this little screen for making big decisions. I liken it to this picture up here. It's a screen to separate rocks from dirt. Everything that's a 0 or 1, that's a problem. 0 is pain. 1 was significantly dysfunctional. Everything else will fall through the cracks. So we're not saying they're perfect. There's still potential for impairment there. It's just that these aren't the big ticket items we're looking for. And as a standalone tool, and this is where Eric was talking about, earlier, and I think he said some things that were pretty profound, and we would agree 100% with this, and that the power really in what we do with our testing is a battery of tests. We need to put them together or combine them. I can say the functional movement screen by itself is probably limited in its ability to predict things that are going on. But we combine it with something like this, as Eric showed, the Y balance test, where we do reaching in an anterior, posterior, medial, posterior, lateral direction, and look for the scores in centimeters or distances. And the target we shoot for is, are they within 4 centimeters reach anterior, 6 centimeters posterior, medial, posterior, lateral. We use this and combine it and put it together and see, does this help us? Now, as I said before with our functional movement screen, one of the tools, or one of the things from a testing point of view that's very, very important to us is the psychometric properties of reliability and validity. Good news is, and Eric sort of reported on this too, it is a reliable test. We can reproduce this between examiners when we look at it, so that's a good thing for doing research. It does seem to identify problems, and one of the biggest ones you can find in the literature with these reach tests is the anterior asymmetry of 4 centimeters or greater than 4 centimeters is highly predictive of a non-contact injury in the lower quarter. Again, we can improve our scores with training or looking at things. So I think these are another tool that could potentially be used. But we saw in our very first slide with Claire, we do know injury is multifactorial. And we look at this injury risk. There's lots of things that go into it. And what I've sort of found with these tests we're using is that in isolation, they're good, but it's not an exact science with things we're doing. When we combine them or use a battery of tests, our diagnostic or predictive yield goes way up. So the question is, how do we do this? And I'll just share one other little tool that we use that has been sort of the biggest game changer for us in at least the decision making to start the return to play guidelines, and that's using a platform we call Move to Perform. And the Move to Perform is a software platform. You can, the web address up here, and as a disclosure, I have nothing to do with it. We just use the platform. But it's an algorithm where there's various weighting interactions included in this algorithm. When we look at previous injury, we look at things such as their Y balance test. We look at things such as their functional movement screen. We look at things such as hop testing, as Eric's had. We could click all these things off. We can look at things such as our selective functional movement assessment where pain was involved. We can add all this whole battery of tests together, and when it's all said and done, the algorithm that we've built, or that comes together with this, it slots the athletes into categories based on risk. Optimal being normal and substantial deficit here. And it's a nice way that we can sort of thin slice out groups of people that are at risk, and it's fairly predictive of injury. In other words, we know with knee injury, somebody that's up in the substantial deficit is 6 times more likely to get injured during the season than somebody's down in an optimal category. And we have a considerable amount of data across all sports in this. So this is a tool, the way we can take tests. Not that you need to have the software to do this. You can do any one of these screens. The message I'd say is we need to combine it. So the take-home message I'd sort of give from this is we do know that injury risk is multifactorial. I think the key to assessing movement is choosing to do a good screen is to choose the right movements we want to look at based on reliability. Is it reproducible? Validity? Are we really measuring what we say we're measuring? And is it expedient? We can come up with all kinds of tests that are great ideas, but if they take hours and hours and hours to do, they're probably not practical for us in a clinical setting to make decisions on when to return to play. And ultimately, we may need to combine the results of multiple tests to produce a better yield or better decision making for our athletes to return back to play. Again, I'd like to thank my friends for inviting me here to Switzerland. I'm looking forward to the next couple days in the mountains. Hopefully see the dogs and snow, I understand, will be here. So again, thank you, Mario, and the organizing committee for having me here.